and welcome to another episode of our incredible podcast. It's now 4.7 stars on Apple and 4.9 stars
We've gone up in the world.
On Spotify. What's it called?
The things I wish my mum told me.
That's
Podcast.
it. Yeah, I was so obsessed with the stars for a moment there.
Yeah.
That, I'm so happy.
You was very upset when they went down.
Yeah.
But now we're back up at the top.
We're back up at the top, baby. One of my friends who had put 5 emoji stars in her review of the podcast gave us 1 star and brought the review right down.
Yeah. And then she messaged us and said, I'm really sorry, I'm not good with technology.
Yeah, she was very apologetic. So she's changed that and now we're all back. Anyway, we've got a very important topic to talk about today. And I want to say thank you to all of you who got involved. And don't forget, if you are listening to this right now, if you are watching it, you can leave us a review or a comment. You can rate the podcast. It really all helps. But so many people got involved in today's topic.
Yeah, because we were talking about something I feel like not a lot of people talk about, but a lot of people are interested in and want to talk about, which is women's fertility.
Yeah, and men's fertility. Fertility all round. But also I think it's one of those things that, like you were saying, you were surprised that women who are in their, early to mid-20s have sent through a lot of questions. And it's something that people are really thinking about.
100%. We had so many responses on our Instagram for questions that we're going to ask our guests today. So we're going to try and get through as many as we can today. There is tons.
We have an incredible guest. Don't know what's wrong with me today. I'll try and learn how to talk. Guest joining us today. His name is Dr Sarris. He's a consultant in reproductive medicine and the director of King's Fertility. Let's welcome Dr Sarris.
I can clap myself, yes.
Give yourself a round of applause. Dr Sarris, just before we get into the questions, because we've got
a lot.
Can you tell us a little bit about you and why you decided to pursue a career in reproductive medicine?
Wow, I mean, that really goes back almost to the basics of myself and who I am. To be perfectly honest, of course, I wanted to do medicine, and that's sort of the starting point. And I was actually thinking what sort of medicine I want to do. And there are a few sort of things in my life that sort of pushed me to it. The first one is, as a younger person, I love traveling a lot. And I've been spent a lot of times in airports, usually on my own, waiting either to arrive or to go. And I remember once, this is a very specific a moment where I was looking at the departure lounge, and a lot of people were hugging and was sort of saying I'll miss you and I'll come back and it'll be nicer to see you. And then I turned at the arrivals lounge and I saw everybody coming in with balloons, waiting and happy and, clapping and tears of joy and whatever. And I realized that most of medicine, what we do is try to make sure that we have health and to prolong our life, but effectively, we all end up in the same place as a departure lounge. But then I realized that reproductive medicine and obstetrics was the arrival lounge. I wanted to be there at the beginning. So that's sort of where it sort of started. And that's how I became obstetrician and gynecologist to start off with. But then what sort of kind of made me really want to do fertility is I realized that there are 2 sort of instincts that we have as any living being on this planet, which is common. It doesn't matter if you're an amoeba all the way to a human or anything in between. And that is survival and propagation as a basic instinct. And actually, a lot of animals just need to survive enough to propagate. You've got the giant octopus that sort of lays its eggs and then sort of protects them until they hatch, and then it dies from exhaustion and so on and so forth. And I realized such a powerful emotion. And my other hobby is cooking and eating, but I'm not a professional chef, obviously. So I decided I've got to do the other thing, which is actually reproduction. And that's sort of how it all started.
Yeah, there's so many emotions attached to it, I think, as well, isn't there? Once someone decides it's something they want, and I've spoken about on the podcast having a miscarriage earlier this year, and that the kind of emotion and pain that goes with that once you've decided that you want something and then it's taken away from you, like how painful that can be. I think that the first question that I'd like to ask, I know we've got loads, but and I know this one has been on there a lot, but as a 40-year-old woman, there is kind of, I guess, lots of content out in the world that says that at 34 suddenly your egg reserves just drop and you suddenly become way less infertile than you were the day before you turned 34, and that's that's it. And I know there has to be a post somewhere, but how true is that?
Well, I think it's just just a little bit sort of starting with the point of, how it becomes all consuming. Fertility is one of those things that if you're not thinking about it, doesn't bother you. And the moment you want to, you can't stop thinking about it. And that is very true. And I see it quite a lot with my sort of patients. I think what's important also to say is that fertility very rarely is a black and white thing. There's no sort of sudden cliff or sudden. Very, very few are things that really is what are referred to as absolute infertility. You know, no uterus, no tubes, no ovaries, no sperm. Yeah, some things are absolute, but beyond that, it's just a probability. And what happens with age, and as might be known to quite a few of your listeners, are women are born with all the eggs they're going to have. So over time, those eggs are used up, and there comes a point where the normal eggs, and that is the menopause. And that is a fact that we haven't managed to change in medicine. So there is, again, a point beyond which a woman naturally with her own eggs can't fall pregnant. It doesn't mean she can't fall pregnant with other methods like egg donation, and that's sort of another sort of interesting sort of topic to discuss. But also natural pregnancies, if we look at which is the oldest woman ever to have been recorded to have achieved a pregnancy naturally, it's actually the British woman back from the 80s, and she was 56. Wow. So, you know, although there are these cases, they're the rarity, but women do fall pregnant in their 40s as well. It's just the chance of it happening is less than what it would have been before. So it's about probability rather than absolute improbability, unless you reach that stage where it is absolute, like no periods, no eggs, no tubes, no uterus, no sperm. And even then, there's things that we can do to help. So to an extent, is how far you want to go. When we look at fertility, are you looking to be pregnant with and have without help, with fertility assistance? How far are you willing to go into your choices? How big a family you want? You know, all this come together into the building and family sort of building notions that people have. And interestingly, it's one of those things that you have to start thinking quite early if you actively want to do something about it. But it's one of those things that we only start thinking quite later in our lives.
Ta-da!
Because I was just saying before, I'm 27 and I've never thought about my fertility really, or like egg freezing or having children, or what age I want to have children. And yeah, so I feel like it's one of the things that you're not thinking about until I need it right now.
You do have a good fact though.
Yeah, I have a good fact that I learned because I read a book. I did read a book. I did English literature at GCSE. No, A level. Anyway, so my fact is, you're born with all the eggs. I feel like my microphone's low. You're born with all the eggs that you will ever have, so that your eggs were also inside of you when you were inside of your mum. So your mum actually if you're going to have a child, had your child inside you as well. That's my fact.
Incredible, isn't it?
Well, it is incredible. Actually, what is more incredible is how early that starts. I mean, this is really, for me, the fascinating thing about talking about how, nature's thinking about the next generation before we even know about it. The cells that will become eventually the cells that will become the eggs and the sperm in the future come from a part of the embryo called the yolk sac, which starts developing only a few weeks into the pregnancy, before you even know that you're pregnant, possibly before even you've done your pregnancy test. Already that embryo is developing the eggs and sperm cells that it's going to have for when it is an adult, for the next generation. So it's one of the first things that happen in development of the embryo. Only a few weeks in, is already thinking about the next embryo, the next generation. I find that fascinating. It's not an afterthought. It's literally there at the beginning.
Wow. That's crazy.
It is. Now you can add that. So when you go add to your fact now, you can be like, hey guys.
My fun fact to everyone at
like
the
dinner
pub.
party.
Yeah.
I think it's a crazy fact. I agree.
I love that. Do you want to start then?
Yeah, let's do it.
Shall we start with our questions? Okay. So a question that we had a lot was, is it true that the longer you are on contraception, the less fertile that you'll be in the future?
No. Straight up, I can tell you straight away. Of course, it depends what contraception we're talking about. It's a lot of different contraceptions. I think it's probably obvious to people that if we're talking about barrier contraception like condoms, it makes no effect to one's fertility. So I presume what we're talking about would be hormone contraceptions and stuff like the coil, for example. So what is potentially true is if you've been on hormone contraception for a long amount of time, especially if it's the depot injection or certain types of pill, it can artificially suppress a little bit what appears to be your ovarian reserve, but it does come back after a few months off the hormones to what it would have been. So it doesn't decrease it. It just might mask it a bit, but it is reversible. And the other thing, obviously, that can happen is that because over time, people obviously don't know what the fertility is. When they come off contraception years later and it might be low, they might think it was the the hormone pill or depot they were on, rather than in fact that was always what they would have been. They just didn't know. But I think a second point, and this is relevant, is that sometimes you can get a bit of time between your periods coming back. So it's what we call, for example, post-pill amenorrhea, which means no periods and no ovulations. And of course, then you can't fall pregnant. And the same thing with you in the depot. So it's not that it will decrease your fertility, but it might delay a little bit the resumption of your fertility. But the eggs that women are born with, which is what we were talking about, are still being used up, which is why also if you're not having periods, for example, because you're in the pill, doesn't mean you're in the pill for 10 years, you don't have periods for 10 years, suddenly your menopause will be 10 years later. It doesn't work that way. In the background, the eggs that you're born with are still being used up. It's just that they're not being released. So again, another thing that you can't do is prolong the amount of time you're going to have your fertility for. That's pretty much innate to what you're born with. And then what happens to your life. That's very important to say. It's not just about how you're born with, it's nature, but also nurture as well.
On the topic of periods, does or can irregular periods kind of signify that there's an issue with your fertility?
Yes, I mean, in a very basic sort of way, fertility is very simple. It's one egg, one sperm at the right place at the right time. That's all that it is. And of course, that's where all the difficulties potentially start. So one of the fundamental things that you need to fall pregnant is to have eggs being released. And that happens within a cycle. And if you have regular cycles, and what I mean by regular, every 3 to 5 weeks apart. It doesn't have to be on the dot every day, every month, all the same. But it has to be relatively 3 to 5 weeks apart. Then you release an egg. That's assuming you're not taking hormones and you're not sort of obviously manipulating your periods, let's say naturally now. But if you have irregular periods or no periods, then you might not be releasing at all eggs or releasing very few eggs. So you can imagine if you have a period once a month, let's say 12 months in the year, so 12 periods, if you have only half of your periods, only half of the eggs, automatically it takes half the amount of, well, you have half the amount of chances to fall pregnant. However, saying that, why women would have had irregular or erratic periods or no periods can vary from the many different reasons. And what's important is it sometimes can signify a very high number of eggs. So there's a condition called polycystic ovarian syndrome, or it can be on the other spectrum where there's very low number of eggs, which is, for example, what happens close to the menopause. So having erratic or irregular periods does not necessarily signify a lack of eggs. It could be the opposite, but it does signify the lack of regular release of eggs for whatever reason, and then that affects your chances of falling pregnant because you have basically fewer chances for that to happen.
You have a question about your own question about periods and fertility, don't you?
Yeah.
Let's hear it. Let's hear it.
Okay. So when I went on the pill when I was 15, maybe, the hormonal pill. And I used to have really heavy periods when I was younger. Went on the pill, was on it for about 7 years, came off it. And then since then, my periods completely changed. I used to be heavy for like 5 days. Now I'm on for like 2 days, maybe 2-3 days. And so it's not something I'm super worried about, but I'm like, has my period just changed over time with age? Or is it that I'm less fertile? I think a lot of women think if you have a short period, that means you're less fertile, or have I don't know, the environment can't handle a baby. So yeah, I guess my question would be, does a shorter period mean you are less fertile? Yeah.
Now, just to clarify, when you mean shorter period, you mean the amount of days
Days,
bleeding or
yeah.
the amount between your periods, the amount of days bleeding?
The amount of days that I'm having my period.
Yeah. Okay. Well, there's a lot of reasons why. Well, first of all, as you know, I'm not going to tell you, but you know it already, women have different amount of bleeding with their periods, different duration, they can have spotting or not. And sometimes you can have variation of normality, sometimes it can be because something has occurred or happened. And that's where sort of the history is relevant. Just having a change necessarily does not mean much. Actually, it's important to say that women's periods, how heavy they are, potentially how painful they are, the length of them does change over time. You tend to, when you start your periods, to be a bit more erratic and it can be more painful, and then they normalize usually, and then later on they become shorter and they can change. And of course they change after pregnancy and all sorts of things. But sometimes it's important to say that a change in a pattern of period can and the heaviness can imply that there is something that potentially is going on. Not necessarily that something affects the fertility, but something. A good example for that is if the periods suddenly become heavy or you start having spotting between periods, it could be that there's a small little polyp inside the womb which can be removed, or that there's fibers that are developing, and that changes over time. So it could be something which is relevant. Most of the time is not, but it's difficult just to dismiss everything. At the same time, you can't be worried at everything. I think the relevant thing is if somebody is worried about a change of period, they can just have a check to see if there's anything like anatomically going on, infections, or as I mentioned, polyps or fibroids. But beyond that, the heaviness of the period is not relevant to what's happening in your ovaries. That's relevant to what's happening in the womb and the uterus itself, for example. What you do get to occasion, if you have women with irregular periods, then the heaviness of those periods can be different depending on if it's a shorter cycle, a longer cycle, what's happening. And of course, that can then tell you what's happening with the ovulations. But then it's not necessarily the heaviness which is the problem, but it is the duration and the irregularity of them as well. I guess the final thing to mention here, of course, if somebody's had a surgery for the uterus and the womb or whatever, and there's been a change of period, sometimes that can be because that was what you wanted to do. For example, you had heavy periods, you had fibers, you remove them, you have normal periods, or because potentially there was a complication or not that made periods very light, and the conditions that can do that. So it's not a straight answer because it depends, but it doesn't always necessarily mean that there's something wrong.
Yeah.
It just means if you need reassurance, just check it out. If everything looks fine, just leave it at that. And it's one of those things that you just can't explain 100%.
That you're very lucky, because I would love to have a period that lasted for 2 days.
I know people do say this, and I am quite regular, which is good. But I feel like as I'm getting older as well, I never used to have cramps or anything when I was young, and I had really heavy periods. As I'm getting older now, I'm getting more pain during my period, which I'm finding like crazy. But I
then
guess
maybe
they
you should have it
change.
checked out then, though, should you?
Yeah, I
Or-
mean, of course, interesting. One of the other things that is very much underdiagnosed, or if it's not just necessarily underdiagnosed, but it takes a very long time to get diagnosis, are conditions like, for example, endometriosis or adenomyosis, which do develop over time. You're not born with them necessarily, actually not born with them at all, although there are genetic components to it, but they develop over the lifetime of having more periods. So things can develop, and again, it can be a sign of something. But again, it
Could not
doesn't.
be.
It cannot be.
Yeah.
So I think it's one of those sort of it could or cannot be. The only way to know is in a case-by-case individual assessment, and that's all you can do.
Speaking of conditions, people have asked a lot about PCOS and endometriosis. How common is infertility with polycystic ovaries?
Well, I think it's important to say that polycystic ovaries and polycystic ovarian syndrome are two different things. And there's been a lot of confusion over the time. And also we've changed our definition recently from what used to be an old definition to now. So just very, very simply put, polycystic ovarian morphology, which is what a lot of the times people get confused with, is quite common. It basically means you do an ultrasound scan, you look at the ovaries and you have lots of follicles or where eggs are developing. So lots of follicles is not necessarily a bad thing. That means you've got a good ovarian reserve. But if there's a certain number and above of these follicles, we call them polycystic ovarian morphology. It means it looks like polycystic ovaries. Now, it's a rubbish term because these are not cysts. And really, unfortunately, it comes from a long time ago when ultrasounds were not that good, and whatever looked like a fluid-filled area in the ovary, we call it a cyst. But they're not cysts, and it's important to say that. They're just lots of little follicles. Okay, well, that can mean you have lots of eggs and a good ovarian reserve. That's not the issue. But and that's can be quite common. It can be up to 20% of women, obviously depending on an age group, because over time, you do have fewer follicles, so over time the number of women with many follicles goes down as well. But then there's a subset of women that's probably about only 1%, just to give you sort of the difference of numbers we're talking about, where they have this syndrome. And polycystic ovarian syndrome then is not one thing, but it's an amalgamation of effectively having increased levels of the male hormone called androgens, because actually there's no such thing as a female and male hormone. We all have the same hormones. It's just what proportion we have them in our bodies that changes, if that makes sense. But you have a slightly higher set level of the male hormones, which then gives side effects of, well, the male hormones like acne and Hirschsprung, which increase sort of hair in this sort of pattern that you get sort of in chest and back and stuff like that, or male pattern baldness and the rest. So you get more symptoms of that. So that's one effect that you can have. And the second effect is you get irregular periods and lack of ovulation. So when you have that sort of kind of picture, that is then called polycystic ovarian syndrome, and that can affect fertility in multiple ways. The first one is, well, very simply, as we said, you have irregular periods, you don't release eggs very frequently, or not at all in some cases, in which case then it's less likely to become pregnant from a simple point of view. We also know that women with polycystic ovarian syndrome have a slightly higher risk of miscarriages, and if they do get pregnant, slightly higher risk of complications in pregnancy, like gestational diabetes and so on and so forth. But it's not something that it's a contraceptive in itself. It can be treated. It is a contraceptive if you don't have any periods, but it can be treated. There are medications that can be used. There are treatments. And interestingly, polycystic ovarian syndrome is also associated with what we call insulin resistance, which is sort of the way that the body handles sugars and insulin and the rest, which is the hormone that regulates it. And dietary changes and weight sort of changes can affect not necessarily that you have polycystic ovaries, that's just the ovaries, but the regularity of the periods and then being able to fall pregnant, and of course then be more healthy in pregnancy as well. So it's one of those sort of conditions that are quite common, but not everybody that has been labeled as polycystic ovary syndrome actually has it. They just have polycystic ovary. And there's a lot of confusion as well. And I spend a lot of time in my clinic trying to explain the difference between the two, because they have a different implication how you treat and also long-term sort of prognosis, as we talked as well.
The description you gave of having polycystic ovaries, not syndrome, but polycystic ovaries, sounds like it's a positive thing, though.
Yeah, to a certain extent, the more eggs you have, the better it is. Greed is not always necessarily a bad thing, but there is a limit after which the problem with polycystic ovarian syndrome is that you also get lower quality eggs. So that's why the syndrome versus just having lots of eggs is a different thing. And yes, on its own, it's a positive thing, absolutely.
Who knew?
I didn't know.
There you go. You learn
Well, that's why we're here.
every day.
That's why we're here.
A lot of people were also asking, are fertility issues genetic? So there have been people who asked us questions who their mothers had fertility issues and they're wondering if they're also going to get that as well.
So it's an absolutely fascinating question that we get it all the time. I think it's important to say is that genetics, it's the new frontier of medicine, and we're understanding more and more. And my generation of doctors is very interesting. I say this sort of from everyday life. I sort of grew up in an analog sort of childhood and have a digital adulthood, and the same things happen in medicine. We grew up with thinking simple, medicine, and now we're moving on the genetics and pharmacogenetics and the rest. So there's a huge field, and anything we say now is going to be probably obsolete in a few months because more knowledge will come out. But the basics of it is the following: is there are a lot of things that we know are structural, which are cause of fertility. If you had an ectopic pregnancy, for example, you have a tube removed, you've had surgery, and you had problems with the scar tissue, then these are structural things. However, there are a lot of new stuff that is coming out to understand that there's a lot of genetic components. Now, you have the very, very simple, big stuff that we knew for a while. For example, if your chromosomes are not in a certain form or type, then it can cause problems with infertility. For example, with male infertility, or with a female, or with miscarriages. So these are basically big lack of in your genetic code. Effectively, chromosomes, the equivalent of having entire sort of volumes of books, and you're missing a book, or bits of the book, like an entire chapter. That's sort of the chromosomes. But what we realize more and more is we have these thousands of genes, and the genome is the letters and the words in the page. And if you have little spelling mistakes, then it affects, it's actually what makes it all unique. But more and more we're finding that there are genetic conditions that affect everything in our body, from miscarriage and onwards. A very good example is recently it came from the big genome project that was going on in Cambridge, and they looked at the genes that affect the menopause. And without wanting to go into much detail, they found it's a few hundred genes, some exact number now, I can't remember, it's about sort of a couple of 100, 300, somewhere around there. And some of them have an effect only by a few weeks or a few months. So in themselves, they're not very important on their own. But put all those hundreds of genes together, they can explain how you can have some women that effectively almost never go into having periods, and they have a very early menopause from late teens or even 20s all the way to actually 60 and beyond the menopause. And it's all that sort of amalgamation of everything and all those thousands of little differences that makes us sort of unique. So there is a genetic element, for example, how many eggs a woman will have, or much sperm a man will produce. But it's important to say that it's also how we interact with the environment. A very good example for that is that there was a study that showed that if women smoke, their male offspring will have a lower total sperm count than if we're not smoking, because the smoke affects the development of the testes when the male baby is still sort of inside. So it is genes, and it's how those genes or interact with the environment as well. And it's the brave new frontier of medicine that we're entering, and that's absolutely exciting. And we will get more and more. We're just not there yet, but it's rapidly changing.
And also, I think it can be quite difficult as well if you don't know like that much about your family. So you might know, it might be like, oh, my mum had issues with fertility. Does that mean I'll have issues with fertility? But you've only got a certain amount of your mum's genes. You've also got a certain amount of your dad's genes. So then there's the women on their side of the family. And then also your mum, you might have via your mum skipped her genes but got some from your grandma. So there's all of those. And even like within my family with the BRCA gene mutation that I've got, my mum had it, my sister had it, I have it, my brother doesn't have it. So now, it's just luck of the draw, really, I guess, isn't it, as well?
Yeah, absolutely correct. And it's, to get even more complex, you might even have the same genes, but it's what we call penetrance, which is basically how much does that gene affect you specifically in that generation, which might be different in a different generation. So you're right, we're never one parent, we're actually a combination of two, by and large, because those were the three-way IVF that people be talking about. That's a different thing. But let's assume that most of the times it's two sets of genetic code, and you only half of each of that sort of side. And then there are changes that happens, what we call de novo mutation, which means new stuff that happened just because that egg and sperm came together, so they were never there before. Then there's the interaction between them and with your environment. So there infinite combinations, which is why we're all unique snowflakes.
But this is why I think it's also so interesting, because what I find is like with having the BRCA1 gene mutation, people who don't know, so it gives me an increased life chance of getting breast cancer, which is why I've had a preventive double mastectomy, and it gives me an increased risk of ovarian cancer, which really I probably should have my ovaries removed, but I'm not even approaching that at the moment. But what I find is really interesting is that when you study and find out those things, and then we have the kind of, the medicines that have allowed me to have the mastectomy, or, those preventative measures, there also should be studies surely of the people that carry those genes, but then it doesn't develop into anything, because what are the lifestyle, conditions of those people that are, because that's the really interesting thing. And I suppose what you're saying, Dr. Sarris, as well, is the more that we look at genetics, we're all going to carry things that could, gene mutations that could lead to heart disease, or that could lead to this, or that could lead to that. But what are the lifestyle choices that we make that either allow that mutation to come to fruition or not?
Well, literally, you've touched upon a fantastic sort of topic, because in itself, BRCA now has been shown, and I'm not a genetics expert, I know enough, so of course, so I'm going to go very simple even for me. So apologies for any genetic people out there that are going to be listening to this. But it's been shown that actually how relevant that BRCA gene is has to do with your family history. So if you have no family history of any cancer, it's actually probably not very relevant, as opposed to if you do. And that shows that, yes, the gene is very important, but it also shows the other genes that are around it. Probably that's why for some families it's more relevant or not. And that's why it's so complex genetics, we don't understand it exactly, which is why doing tests that we don't understand. And this is a concept that around the world is very different. So you go to some parts of the world where, they will test you for everything and anything. And they assume that because they've done it, they do better medicine, as opposed to other parts of the world, they'll take a more nuanced sort of understanding of what has and what doesn't have to be tested. And the problem is we don't actually understand always the results and what they mean to an individual. So your history, your family history, your makeup and your life is what makes it relevant. And actually, the same test being positive or negative on two different people with a different background risk for that particular condition has a very different meaning. Now, this is a very difficult concept that I actually try to explain to my own medical students and my own sort of, junior doctors that I treat.
We've got no hope.
No, but it's very, very difficult, because it's trying to explain to somebody that having a positive test, if you've done it on the wrong person, that can be a false positive test, as opposed to a true positive. And how likely it is to have a test which is falsely positive or true positive is really relevant to who you applied that test to. And it comes down to statistics and theories, which obviously makes it very sort of geeky, so I'm going to stop there. But we can keep on going forever. I always kind of jokingly say that fertility is a bit like and I've taken this obviously from a film, as a layer, as an onion, and you have more layers, and the more deep you want to go, you can go another layer, until pretty much you've had enough, and your eyes are crying,
Crying.
so
You're
you just want to stop.
crying.
Okay. Let's see what we've got next. Someone is asking, what is the best way to track ovulation?
Okay, yes, that's a very common, very interesting one. So obviously, the first thing is to know what your cycles are doing, because very, very roughly put, your ovulation will tend to be somewhere sort of midway, although there are variations there. Now, there are different methods. The first one is you can just use from over-the-counter sort of urine pee sticks that you sort of look
use
at the
them.
hormones, and they can be very effective, and they can look at
Stick.
different sort of peak fertility and high fertility, and basically they track the hormones within the urine, which are relevant to sort of when you ovulate. So that's what we refer to as the ovulation predictor kit. So that's sort of one way. Another way is you can track it in a natural way. So we know that there are changes in the heart rate, so your sort of basal heart rate changes, and your temperature, your basal temperature, and also the cervical mucus as well. And it can be a very, very effective way both for natural contraception on a population basis, and also for natural conception as well. That does entail knowing your body. And actually, to be perfectly honest, now with all this sort of variable technology
And the apps.
and the apps and the wearable technology, can actually tell you and track your heart rates. In the past, you had to have your own charts. And I remember when I was sort of training, and when we come with these little paper charts and the mucus thing and the temperature, and they would do it daily. Now you can almost do it much more automated. So there's the natural sort of way of sort of knowing your body with the changes that happen physiologically throughout the different stages of the cycle. What we said about sort of urine predictor kits, and actually, to be perfectly honest, if you have a really regular, predictable cycle, and you sort of manage to work once or twice when your likelihood is when your ovulation is, then obviously it's more or less going to be there. Other times when we can actually feel the ovulation, we can get sort of ovulatory sort of pains. That is also another sort of sign of it as well. So there are different sort of ways for people to work it out. If you have a very irregular period, then it becomes more tricky. And that's possibly where asking for some advice and help, and maybe monitoring and tracking. Of course, the most sort of advanced ways you can do with a doctor, where you can do scans and blood tests and the rest. But we're talking about at home, easy to do things, not come to somebody like me and doing sort of fancy tests and so on and so forth.
How long should someone wait before they go and see a doctor? So how long should they try for a baby naturally, and then it's not happening, and then go and see a doctor? What's the kind of time frame that you would say?
Well, so infertility is defined by the World Health Organization as trying for 12 months with regular unprotected intercourse and not having a pregnancy. But that is in the context of somebody that doesn't have a known medical problem, and I'll come to that in a moment. And there's also sort of the age effect. So basically, if you're less than 35, I think if you're over that, although it takes longer to fall pregnant, the rationale is maybe after 6 months you can seek some sort of advice, not necessarily because you can do anything, just to make sure that there's not something that you're missing from a cause of infertility, and then you can act on more quickly because time is more relevant. If, however, you have a known cause of infertility, then of course sooner. So I've had occasionally cases where I had couples have been trying for 2 years. I say, okay, well, let's go through the history. And it turns out that the woman only had like one period every 6 months, in which case you kind of think, oh, well, in this case, you should have pretty much come straight away, because the problem is you don't have periods. We know there's an issue, or at least I know there's an issue, and we could have maybe saved some time. Same thing, for example, if somebody's had surgery and they had a tube removed, for example, and you know about it. So in that case, you don't need to wait necessarily. Not that, again, it means you can't fall pregnant spontaneously. As I said, very few things lead to sort of absolute inability to fall pregnant. And if you know about them, so for example, we know that men that have cystic fibrosis do not have sperm in the ejaculate because the tubes that connect the testes to the the ducts to come out are not there, then pretty much straight away you need to see somebody. So it depends a little bit if you know or not. But just to, very simply, if you don't have a known cause, you're less than 35, 12 months of unprotected intercourse regular, not once every 6 months. And if you're older than that, then you can seek advice sooner to know, not necessarily that you should jump into doing anything.
Yeah.
At what age does your fertility start dropping? Like, is there a prime age to try and get pregnant at?
Yes. Well, pretty much fertility starts dropping straight
moment
away.
you're born.
That's what I was saying
You
to
know,
Clara before.
so just to put in sort of context, when you're in the womb, sort of as a developing, you have about 7 million eggs. By the time you're born, you have about 1 to 2 million eggs.
My God,
By
it
the time,
disappeared in
That's
there.
crazy.
yes, by the time you start your periods, it's about 300, 500,000 eggs. And actually, by the time you have your menopause, you probably have, well, no usable eggs, put it that way.
Mm-hmm.
But you only release very few eggs in your lifetime. If you think about it, there's one egg per month, 12 months in the year.
Yeah.
If you have periods between 15 to 50, just to make it very simple, it's 35 years. So 35 times 12, there you go. It's about 400, 500 eggs. You don't release all of them, but you do use them. Because for every egg that you release, a bunch of them competes for it to be released the same way that there's millions of sperm in the
Wow.
ejaculate.
Really?
didn't
But
know
yeah,
I always thought there was just one egg that's released.
But they have a
lives
fight
for
and
24
decide
hours,
which
then
one's
it
going to be
dies.
the best
it is.
one.
You're right, but it's but
What
for
happens to
every
the others?
well. So what happens is, I know we digress from the question, and I will come back to it. I promise. I do. I will come back to it.
Wait.
But what happens is that you are, as we said, born with all the eggs you're going to have. The eggs don't come on their own. They come with a little gaggle of cells that support them. So we call them follicles. So when we refer to follicles, in your mind, you can imagine it's an egg with the cells that supports it. So you're born with, these 1 to 2 million follicles with our eggs called primordial follicles. But from birth, some of them will get activated, and they'll enter that sort of journey to be released, hopefully, later on. So we don't exactly know why some eggs will get activated one day, in a month, in a year, 10 years. We just know that they start getting activated. So once they get activated, they start this sort of journey, which in sort of, typical textbook sort of talk is about a year. There are exceptions to everything, and not everything necessarily is textbook, but let's take it just at face value now. So it enters this first stage called a primary, secondary follicle, all very non-interesting, because really we don't know what's going on. We can't measure it. There's no hormones we can see. The only real reason we know about it is because when people have taken ovaries out of women and opened them up under the microscope, you can see these things. But the exciting stuff happens the last sort of 2 to 3 months. And that's where this 3 months for everything comes in fertility, 3 months to take your vitamins and whatever. So in the last 2 to 3 months, they enter this stage called the tertiary or antral follicle, which basically is the same follicle with an egg, but it has a little fluid-filled area within it, which has been secreted. So now they become bigger. So now when you scan, you can actually see little black spots in the ovaries. You can count them. So it's the first time we can see them. The second thing they do is they start secreting this hormone called AMH, anti-Mullerian hormone. Technically speaking, it's from a group called the preantral and early antral, so slightly overlapping group. But now we have sort of 2 ways to be able to measure what's going on in the ovary for the first time. But although that's interesting for somebody like me, who's a doctor and a bit of esoteric value, what does it mean to your body? Well, actually not much, apart from one thing. At this stage, this is the stage where these follicles, up to now, were on autopilot, and they were doing their own thing from birth, which is why it doesn't matter if you're in the pill, doesn't matter if you're still a child, you're still using up those eggs. But at that point, they start to express around them receptors for this hormone called FSH, follicle stimulating hormone, like little antennae that comes out. And this effect is the first time this follicle is going to be spoken to from your body. So what your body does at the beginning of the month, it secretes this hormone called FSH down to the ovaries. And you can imagine that the FSH is like a key, and these receptors are like sort of a keyhole, and then you have a room, which is the follicle, and an egg inside. So the moment that the hormone comes down to the ovaries from the brain, all those follicles that you had at that moment in time, doesn't matter if it's 1, 5, 10, 20, whatever I've seen on the scan when I'm scanning, and we're talking polycystic ovaries and everything, they see this hormone, they start to compete, because eggs are not friends. They want to become a baby, so they compete with each other. We're the same way that the sperms are not friends. That's why you have million sperm in normal ejaculate, but they compete. And one becomes the biggest, the best, and the dominant one, and that's the one you're going to release. And all the other ones that tried that month and didn't make it, they die off. It's a process called atresia. So the same way that millions of sperm in the ejaculate, you try a month, if the sperm doesn't find the egg, they don't hang around for the next month, they die off. You need a new bunch of sperm. The same with the eggs. There's a new bunch, like a conveyor belt. So for every one egg you release, you have this number of eggs that has been trying to get that stage. And that's why you use all your hundreds of thousands of eggs when you first start your periods, and you only release a few hundred. And that sort of is what's the sort of fascinating about it.
Wow.
And I forgot what the question was we started with, because it had nothing to do with this. What was the question?
It was about the the kind of prime age, I guess.
Yes.
And what?
So numbers is one thing, but also then it's about normality of eggs. And what is quite fascinating, a little bit disappointing in human reproduction, is actually how bad we are at creating our eggs and sperm. Most of the eggs are not normal. And this is unusual in many ways, because for other animals, for example, for mice, where a lot of experiments are happening, almost 100% or normal. So it's very unusual that we have a lot of eggs which are not normal at any stage of one's life. I'll give you some numbers in a moment. But what we mean by a normal egg, we basically mean it needs to have the normal chromosome numbers, which is the building blocks of life we're talking about. So you need obviously half from the egg, half from the sperm. They need to be a normal structure. They need to have enough energy, the eggs, and structural morphology and all sorts of things. So when you look at the number of eggs which are normal, actually only a small proportion of them can give us normal embryos. So we think, for example, if you're less than 35, you need about 4 to 5 eggs to have one normal embryo. Not all of them will implant. If you are, sort of 40, that sort of comes down that you need about something. You need sort of 15 eggs or so. About 15% sort of your eggs will be normal, and everything sort of in between. And when you're above that, it's about like 1%. So what tends to happen is you have fewer numbers and fewer numbers which are normal. So it becomes a compound effect. So if we look at sort of the best time, rather from a biology point of view, because that's very different from where you are in your life point of view, that hasn't changed over time. The best sort of quality of eggs and number of eggs are for women who are in their 20s, early 30s. Now, it doesn't mean that you don't have normal eggs later on. It doesn't mean that you can't fall pregnant. That's why, coming back to what we're saying, that women can fall pregnant in their 40s and actually even in their early 50s in rare occasions. But by and large, statistically, most of the normal eggs will be in the 20s and early 30s. And that will be biologically the best time from an ovary point of view. Interestingly, 2 young ages also increases the number of normal eggs for a slightly different reason. So actually, less than sort of 21, so teens, actually have more abnormal eggs than you do later on. So there are reasons. I'm not going to bore you with why that happens. So it's not that it goes the younger you are. There is sort of an optimal spot that tends to be sort of early 20s, sort of to early 30s, from a natural conception point of view, biology point of view, not necessarily from when is the right time for a person point of view.
Yeah.
On that topic then, so because I know that obviously I spoke about the fact that I had a miscarriage. So normally when it's an early miscarriage, is it normally chromosomal abnormalities, which I guess is what you're talking about. And does that increase then as you get older? Because like you're saying, only a smaller amount of those eggs are normal, but some of them could still get fertilized, but then your body goes, actually, no, this isn't going to work.
So miscarriage is an entire subject and on its own, and of course a very big black box because so much we don't know, and we make so many assumptions about things. But the vast majority of miscarriage will be because of a problem with the embryo of some sort, chromosomes or structures or fragmentation, all sorts of little things. And then, of course, there are reasons why we're more likely to miscarry because of things with themselves in the body. And there is this sort of kind of assumption and theory that the early on a miscarriage, the more likely was to be an embryo, the later a miscarriage was, or for that matter, late miscarriage or even later than that, it's more because of something was happening in the environment. It's a very sort of big generalization of that. But coming back to the miscarriage that you're saying, you're absolutely right. Having eggs which are not normal, one thing is they might not fertilize, or if become fertilized eggs, which are now embryos, they won't implant, so you won't be pregnant. But if they do implant, they're more likely then to miscarry. If they're abnormal, they will miscarry. So of course, more abnormal embryos you have, the more likely to have an abnormal one that will implant and miscarry. And if you look at very sort of crude statistics about it, if you're, again, in that sort of age group we're talking about, sort of 20s, early 30s, about 1 in 5 pregnancies will miscarry. If you're sort of your mid-30s, it'll be 1 in 4. If you're sort of 40, it'll be sort of 1 in 3, and then sort of mid-40s, it'll be 1 in 2. And actually, by the time you're in your late 40s, almost 95% of pregnancies will miscarry. Now, a lot of this might happen before you even know that you're pregnant. Not necessarily mean that all of them will be, after you've had a scan. But the miscarriage rate goes up as we become older because exactly of that.
Okay.
I think a lot of people as well were asking if having a termination of a pregnancy will affect your chances to then get pregnant again in the future.
Yeah, so having a miscarriage or an abortion, if either one of those things can impact your chances of being pregnant
again.
I guess they're slightly different things because the question is also why you had the miscarriage versus, for terminations, most of the times well, by definition, the pregnancy was ongoing. Otherwise, it would have been a miscarriage. So that makes sense. So slightly different. But I think what I want to reassure sort of your listeners here is that by and large, the answer is no, it shouldn't affect. I put a caveat there because, like most things in medicine, depends if you had a complication or not. So if you had a miscarriage or a termination for that matter, and there was a complication, what do I mean by that? For example, there was infection following the miscarriage or the termination, or there was a surgical management of the miscarriage, and there was a complication from the surgery, or so on and so forth, then of course, some of those complications can have an effect later on in fertility because if they've caused sort of some injury, but not in the fact that you had it in itself, a miscarriage or termination. And the vast majority of miscarriage and the vast majority of terminations are conducted without sort of complications. So the vast majority of the time will be fine. But yes, there are occasions where there can be an issue. That's that little caveat there, if that makes sense.
How and where do people find out about their fertility prior to trying for a child, and when should they do that? Because just to put into this conversation, I'm going to be having a fertility MOT at King's Fertility with Dr. Sarris, and you know, maybe we can talk a little bit about what that means, because I'm guessing that would be the place for someone to start. But only if
I
they
want one now. No, I want one.
But
now.
I think the reason I'm having it is because I am 40, and so I want to know, you know, what's going on, and so then I can decide what my options are, because time is of the essence, to quote Thames. And so I think I'm at a stage in my life where I really need to find out. Whereas I'm guessing that for, you know, the majority of people who might be, you know, younger and whatever else, might not necessarily need to think about that unless they were considering egg freezing. But anyway, let me get back to that, the first question. So yeah, when and how do people kind of find out about their fertility?
So I think the important thing is what you just said there is options. So it depends why you want to find out about your fertility. It is true to say that knowledge is not necessarily a bad thing and education is always a good thing. There have been some studies that have shown that by and large we're, as a population, we're pretty bad at understanding fertility, and we have a misconception as to what how likely things are to happen or not. And that's why there's a big drive international, but also in the UK. So I'm an executive member of the British Fertility Society, so I've got to put a little plug in there to say that they have some very good material for public education as well, if you want to look at it as well, and a very sort of easy sort of way to understand. But the important thing is that there's a lot of studies that show that we underestimate how difficult or how easy it would be to fall pregnant and how fertile we think we are at certain stages of our life. And when you look at sort of the studies that looked at education sort of programs, they found that people by and large found that useful, but it also increases anxiety. Because the important thing is, what do you do with that information? And I thought the other problem is that a lot of the tools that we have, they're there really to help us and guide fertility treatment at that moment, but they're not necessarily good at extrapolating what's going to happen to you in the future. So, for example, when we look at a fertility sort of workup, we do a scan, we look at the number of follicles we're talking about, this AMH, anti-mullerian hormone, which is another sort of measure of fertility. But those are good measures at telling us how likely IVF treatment is to work or not. They're not very good at telling you what's your chance of spontaneous pregnancy in a 3 or 5 year sort of time frame. So the prediction is not very good when it comes down to what possibly a lot of people want to know, which is how much time do I have? And you can never predict that. They're better at telling you if you want to do something now. So there is a little bit of controversy around the sort of fertility sort of MOTs, let's say. And actually, I particularly think there are sort of, we have to be open and transparent with the patients when we see them or with individuals, so they know exactly what information they can't or can't get. I think it's good for somebody who's worried that there's something wrong. For example, if they have fibroids, we talked about sort of, you know, heavy periods, and if they're worried about that. I think it's good if somebody's actively wanting to do something like, should I do egg freezing? Or it's good for somebody who's thinking, okay, I want to know, would my options be, you know, to have treatment with my partner as a single person, or egg freezing, embryo freezing, or nothing, or whatever. So you have an answer that needs sort of addressed, and then that can give you some useful information to then see what your options are. If it's just let me just check what's going on just to see if I've got another 10 years or not, it's not really useful because you can't make that prediction. So it's very much important as to what is the answer you want out of it and to see if we can get it. And I think there has to be a balance between having the information but having the information in a way which is useful and usable rather than just having it for
Just to have it.
for that to have it, in which case can cause anxiety in one side of it, or inappropriate reassurance on the other side. Because again, having everything normal doesn't mean that things will be fine. So you don't want to reassure someone inappropriately or cause anxiety inappropriately either. So it's a very fine balance as well.
So it's sort of something you would want to do if you are really looking to conceive or freeze your eggs right now.
Or to think what your options are. Yeah. I think the number one sort of question I get, well, not number one actually, but the question I do get quite a lot, and I tell them straight up, I can't give you that answer, whatever, is how much time do I have? How much time before I have to start thinking about a family? And the answer, I can never give you that answer because it's impossible. No matter what we find on of a fertility. Yes, of course, there rare cases where you find something which comes back to sort of the absolute sort of infertility. If you do a sperm test for somebody who have no sperm in the ejaculate and then you find out they had something wrong, yes, of course, then you give them that answer. You would need to have treatment to have the children. But, these are the rare cases. If we're talking about population-based sort of screening, which is what effectively, a fertility MOT for everyone would be, that's probably a little bit not the right thing to do necessarily if we don't really know what we can do with that information. You have to have an action point after you have an information as well.
I think a question that I have is, does being overweight affect your chances of getting pregnant naturally, and would it cause complications during a pregnancy?
The answer is yes to both. There is sort of an association between increasing weight and infertility, miscarriages, and complications in pregnancy as well. So it's important to try to optimize the weight as possible. I think it's very important, though. We're not saying that everybody has to become, super skinny and that, otherwise that's not what we're saying. But, there is an association actually with both extremes of being underweight as well as being overweight with, well, pretty much most medical complications. So it sort of makes sense that fertility would be one of them, if that makes sense. So the answer is yes to both. It's always going to be the advice of any doctor. Don't smoke, don't drink too much, try to exercise, and have a healthy weight. I mean, that goes wherever the doctor you're talking to should be saying that to everyone. So it's almost like a truism rather than anything else. But, and again, unless we're talking about extreme situations, these are not contraceptives in themselves, of course.
Yeah. Okay. What did we have?
There was another one there. Is there a right age to check eggs to start freezing them? Because I think a lot of the questions from your followers came about egg freezing as well, didn't they? Because they're, excuse me, they're maybe a little bit younger. And also, I was speaking to somebody recently who's 40 who's just frozen their eggs. So I suppose, optimally speaking, is there a right time to check and then to freeze them?
Absolutely. I think those go hand in hand, if that makes sense. So, interestingly, in the UK, the average age for freezing eggs is 38. However, the optimal age will be for somebody who is, well, exactly what we said, the younger the better, up to the certain that you can't be too young, because then, of course, then you have more abnormal eggs. But these are sort of, quite, much younger, like so teens and less than 21. The optimal age would be 20s, early 30s, because that's when you have the most normal eggs and the most number of eggs. So then the number of eggs you require frozen in order to be able to have potentially a child in the future, or fewer. So fewer cycles that need to be done, more likely to be good quality as well. And there is, again, it's that sort of kind of, old saying, the sooner the better. There's no optimal time because the more eggs you get and the more normal the quality, the more likely it is for that to work. And the problem is, like most things in life, the irony of it is that by the time you start thinking about it, it's probably already beyond. Exactly. By the time you start thinking about it, it's probably already at the stage where it's not as optimal as it would have been before. But also, I have to very much sort of be important here to stress here, because we don't want to over-medicalize things which are not sort of medical, is that the number of people that come back to use their eggs actually is quite small. There's multiple studies that have shown, and we looked at our own data, we only talk about sort of 7 to 8% of people come back, and use their eggs. And of course, the younger that you've frozen your eggs, the optimal number and the better the quality of it, but also possibly, we don't know, we'll have to wait for another 20, 30 years, the less likely you want to come back and use them because you have more time to potentially not need them, if that makes sense. So it almost becomes quite an ironic sort of situation where the optimal time to do it is A, when you're not thinking about it, and B, most likely you won't need it because you have more time and potentially, in your life to have other options. You don't know, and vice versa. So it's about sort of, again, this sort of kind of cruelty of nature when it comes down to sort of taunting us as humans.
How much would the process of freezing your eggs cost?
Again, depends which country, it depends sort of which clinic, it depends where it is. Very, very, very roughly sort of putting it there, just to have some numbers for your listeners. Egg freezing in itself as a process tends to be around sort of most places around sort of £3,000. But then on top of that, you have to put the number of, the cost of the drugs. And again, that will depend on the ovarian reserve. You need high dose or lower dose. That can be anywhere from £1,200 all the way to £2,500, and that is sort of the range of the drug medication, which is the most sort of expensive. So now we're talking about probably around sort of £5,000, let's say on average, and then it tends to be sort of a yearly sort of fee of like £200-300, 300 somewhere out there for storing the eggs in sort of the specialist tanks that are required and also monitored and everything. And then of course is the cost to come back and use them at some point, which again tends to be, again, a couple of £1,000 in today's money, obviously.
There you go.
Crazy.
Better start that saving account now, my friend.
Well, I think we have to stress here as well, and this is important from egg freezing point of view, is that it's not just the cost, but it is a medical procedure, and it's a complex medical procedure. So, there are benefits, but there are also risks. It's not, it's not an easy process. It is effectively IVF, just going 2/3 of the way, which is all the way to getting the eggs, and not the last 1/3, which is making them into embryos and putting them back. It is a medical procedure. It should not be taken lightly. It doesn't mean that it's not effective, that it's not appropriate, doesn't mean that it shouldn't be done. But at the same time, there are camps on this. There are people that think that, everybody who turns 25 should have as a birthday present from their parents, a cycle of egg freezing, a graduation present. That's like one extreme. Then there's the other extreme who says, actually, most of these won't be needed. We should be talking actually more about policies to help people have children younger on a societal point of view, like they do, for example, in the Nordic countries. And then, I think there's always a balance everywhere in between. But we shouldn't forget that it's a medical procedure as well.
Yeah, and I think that you don't necessarily think about how taxing it's going to be on your body, mentally, emotionally, the hormones, like all of those things. And I guess it's something that you suppose you have to kind of gear yourself up for. But I do think it's so interesting. I was a personal trainer, or I am a qualified personal trainer, but I had a client who was in her 40s. And she had a child via IVF, and she used to say to me all the time when I was 25 or 26, she'd say, freeze your eggs now, freeze your eggs now, freeze your eggs now. And I'd be like, why? I've got loads of time. It'll be fine. Why is she telling me that? That's just, I thought it was funny. And then here I am, 40, where I suppose, having frozen my eggs now, when I was in my late 20s, I might be I'd probably be in a really different mental space, because I'd feel like I had that kind of, backup plan with people freezing their eggs, because I kind of looked at statistics and and the kind of chances of conceiving with a frozen egg seem quite low, but then I guess they increase because people have more than one frozen egg, right? So I think on what I was looking at, for different age groups, it was obviously different, but it was around, for example, and I'm not saying that, but around 20%. But then if you had, that's like 1 in 5, right? So if you had 5 eggs or 10 eggs or 15 eggs, then that percentage of an overall pregnancy from them would go up, is what I'm trying to say.
Yeah, you're absolutely right. And it's coming back to what I said a bit earlier, that, greed is not necessarily a good thing, but in actually fertility, when it comes down to how many eggs you have and stuff, or embryos, is not a bad thing. The more eggs you have, the more likely it is to have a normal egg, the more likely that egg is to become then a pregnancy and to be a successful pregnancy. And it's what you're referring to what's called the cumulative chance. So it's basically the chance over multiple sort of either goes, eggs, embryos, whatever you have. And most studies pretty much have shown that there's a linear sort of correlation. The more eggs you have, the more likely you are to have success, and of course then potentially have more than one. And it's actually for all age groups. What changes is what's the slope of that line, and how many eggs you need, but effectively the more the better. And So it really much sort of depends. And, people have calculators out there, what's called ART calculators, to sort of put your age and your egg numbers, what's your chance. Most of those tend to be also mathematical sort of modelings, because the problem with statistics is they work on populations. They don't work on individuals. For individual, it's binary. It's 100% or 0%. You're either successful or not. You're not going to get 50% chance of a baby. Well, actually, 50% of a baby. You'll have 50% chance, but 50% of a baby. Well, hopefully you aren't going to get 50% of a baby. So, they become very binary. And that's where it's really, really difficult. It's very easy for somebody like me, to sort of cerebrate and look at numbers and pretend to be sort of clever, bamboozle you. But at the end of the day, though, on an individual level, numbers mean very, very different things. And that's where it becomes difficult, because even if I tell you, look, there's an 80% chance this is going to work, that's actually 1 in 5 that it won't work. And if I tell you, well, actually, there's a 5% that it's going to work, 95 it won't work, well, actually, there's still a 5%. And I've seen it all. I've seen the 1 in a few thousand happening, good or bad, and I've seen the 85-90% should happen not to happen, and that's sort of where statistics are different from reality of individuals, if that makes sense.
I wanted to talk about a little bit about male fertility, because obviously that's the thing as well, guys, believe it or not. So I've had this one that says, I'm 34, a healthy female, struggling to conceive for over 5 years. My 34-year-old boyfriend is overweight and has high blood pressure, and is so worried he's infertile that he won't get tested. And she said all of her fertility tests have come back normal. Is that something that you see a lot with men? Because I think as women, someone said something to me over the last couple of days, that women have been tricked into thinking that they can have babies later. And I think that's rubbish. We're aware, from the moment we're kind of 10, 11, 12, that we have this ever decreasing, egg reserve, this biological clock that kind of follows us everywhere. So I don't, and also I think we're quite willing to kind of go and seek things and talk about things and process things. But then when it comes to men, it seems like, sometimes they're going to be the problem. It's not going to be us.
Well, I want to take one step further, and I'm really glad about this question. It's not sometimes, it's at least half of the times.
Wow.
Because if you look statistically at what is, the proportion of male versus female versus infertility, and this is pretty much everywhere in every clinic, and I've seen it in our clinic when we do our numbers, about a quarter of the patients that we're going to see, they're going to be predominantly problem with the female side. About a quarter will be a predominantly problem with the male side. About a quarter will be both, and then another quarter is that we don't know, what we call unexplained. So that means about 50% of the people that we see, the problem is either partially or entirely on the male side, if that makes sense. So it's not just sometimes, it's actually at least half of the times. But interestingly, is exactly what you said, is when it comes down to engaging the conversation about male infertility, men are very bad at doing that. I think, women are very much more comfortable talking to their female friends and saying, I've got period problems, or I've got this issue with, fertility, or I'm going through IVF. You're not going to get a bunch of men going down to the pub having a beer and saying, my wife and I can't have a child, and it's my sperm that is the problem. We just don't do that. And that's not right. We need to open that conversation. There's a big drive, and I'm actually a very big supporter of that drive, to open up the conversation for men to be open about fertility, because it affects them. The thing with fertility, though, and why it's a little bit unfair on women, or very unfair on women, is that the majority, if not all of the treatments that we have, apart from trying to optimize sperm, happens on the female side. So even if it's a male side, it'll be the female that has to go through it.
Even if the woman's healthy, and it's the man's sperm, but they have to go through IVF, it's the woman that's going to have to do the hormone injections, that go through the procedure.
Exactly. And of course, that brings a lot of level of guilt from the male side. I see that quite a lot when I have partners, that they know that their partner has to go through all of this, problem because they have an issue, and I can see a lot of guilt there. I'm not saying that it's misplaced, but of course, it's about seeing it as a partnership. This is not about whose fault it is. But interestingly, and this comes not just to fertility, but it's of course why people sometimes won't engage with screening problems for cancers as well, is the fear that I will find a problem. And of course, there's a bit of a paradox there, but the whole point is that if you have a problem, if you can catch it early, there's more likely to be able to treat rather than not, and it becomes a paradox. So, your sort of question, which is the male, the partner, doesn't want to be tested. Now, I'm not saying that there is a problem. There might not be. We don't know. But not engaging with it, obviously, it's a discussion that they need to have together as a couple. Because by the end of the day, as clinicians, as doctors, all we can do is just guide and help people. We can't tell them what to do. We're definitely not going to, drag somebody kicking and screaming to have sort of treatment or not. But what is interestingly, there are parts of the world and different sort of backgrounds where very much infertility is seen as a female problem, even if the problem is the male. And I think we need to break that. And I'll just give you one sort of final sort of statistic to say a bit how sad it is, even in our field, how we sort of approach it. One of my former fellows and colleagues sort of did a little sort of research bit, and they found that there was a few years back now, but they found that of all the publications that are out there about fertility, I'm talking about scientific publications now, and remember we said 50-50 about female-male infertility, 98% is about female infertility, only 2% about male infertility. So even us as professionals are not doing proper service to the need out there by not researching more. So I think that's really a barrier and a frontier that we need to break.
Yeah, and I think I suppose there's kind of like that idea tied to masculinity is like your virility and like, whoa, I'm a man and I can do this, and I won't say any rude words, but and then when it kind of looks like maybe you're the problem, I guess for a lot of guys it's a painful thing that they don't want to deal with. But if he, like you say, if he doesn't go and get help, and if they don't know what the problem is, then nothing can change. It's really not that deep.
I think naturally a lot of men's instincts is to provide, and then when you feel like you can't provide in a way that's really important to have a child, it might affect their mental health a lot
and make you feel less masculine, I suppose. Yeah,
it does. And interestingly, there's a lot of sort of unmet need there as well. Women are, as we said, much happy to talk about things as opposed to men. And again, that's needs to be broken down as well, and people need to talk more about it as well. So thank you for that question.
I think the final question that we'll leave off with is, what is one myth on fertility that you would love to re-educate people on?
Which is one
myth about fertility that you would love to re-educate people
on? Oh, wow. So many. I think the number one myth is IVF cannot overcome fertility problems because of increasing age. I think it's important, people's thinking that, if we just leave it later and have a problem, don't worry, we'll have IVF. That's not true. Although IVF can help at any age, the ability to do so, it's by the end of the day dependent on nature itself. I think it's very important to say that what we do in medicine, we don't create life in IVF. It's very, very important we don't. But what we do is we align the stars and try to put them together in order to create sort of a path for it to happen. But if you don't have the stars there, you can't align them. So we cannot overcome things that are based on age. I'm talking about, again, methods with using your own eggs. Of course, if we talk about treatments like egg donation and stuff, that's a different discussion altogether. And that is, I think, a misconception, that thinking that IVF will work against time. It doesn't.
Okay. Amazing.
I think that's a great point to finish on. And I guess like just from this kind of conversation and opening up this conversation, like from my perspective, I really kind of understand that knowledge and education is power, because it's our own bodies. And even like being sat here today as a 40-year-old woman, there's stuff that I've learned about my body that I didn't know. And so I think we are kind of, kept in the dark a little bit about our own bodies. And we're not talking about, all the terms, etc. that, Dr. Sarris, because we're not quite there yet. We'll try. But just the, the kind of like basics and the inner workings and, all of that kind of stuff. And I just think it's been, for me personally, it's kind of in a sense like reassuring.
Yeah, 100%.
Even if, and I will let everyone know how the Fertility MOT goes. I'm going to vlog it as well. But, we've spoken about, Dr. Sarris, what happens emotionally if what you find out isn't what you want to hear. And I think that, that's something that I've really had to consider as well. It's not just like, oh, I'm going to go and do this thing and yay. But I'm at a point in my life now where I feel like I want to make some decisions, whether that looks like egg freezing or freezing embryos or, like trying to have a baby with a sperm donor, whatever that looks like. I think now is the time in my life where I really want to start making that decision, and I need a start point to do that from. So I just want to say thank you for being with us.
My pleasure. Thank you for having me.
Yeah, I think there's so much mystery for women around our own reproductive systems. So these conversations are really important. So thank you for joining us today.
No, thank you. And I think you can see, just closing from where we started, you can see why exactly I do what I do and why I love what I do and why I chose it as well. Starting from that first question. Thank you very much for having me. And I hope the listeners found it useful.
I think they definitely will have.
I do. And I think if this is something that the listeners want, which I'm sure they will, we could do another episode with Dr. Sarris. And I think what might be nice, maybe is because we had so many questions.
Yeah, we didn't even get through them all today.
No, and so many kind of similar questions, but I think it's quite nice, you know, maybe to focus on like particular
Topics.
like or people's particular kind of really specific questions, maybe a little bit more. But we can do that next time if you're up for it.
Yeah, we can do themes. Absolutely. There's so much we haven't covered. So much.
The new member of the things I wish my mum had told me. Okay, cool. Well, thanks so much for listening.
Thank you so much for having us, for listening to us. Don't forget to rate us, to give us a follow on our social medias, on our YouTube. We drop our YouTube episodes every Wednesday. And yeah, thanks for being with us.
We didn't do Saucy Secrets this episode.
No.
We're not sure Dr. Sarris is ready for that.
We usually do a segment called Saucy Secrets, and it can get a bit explicit. And we thought, let's keep
You know
this
what
out
I
of this
do for a
episode.
living, right? I do fertility. You have no idea what I have seen and heard.
I can only imagine. But if you do have a dilemma, if you have, you know, something that you would like us to talk about, or, you know, in particular, Dr. Sarris, then please email us at mumtoldmepod@gmail.com.
Amazing. Thank you so much. We'll see you next week. Bye.